The definition of a small renal mass: a solid mass in the cortex of a kidney. Imaging features suspicious for a renal cell cancer that is up to 4 centimeters. What was once called the internist's tumor, RCCs are now called radiologist's tumor because most of them are diagnosed incidentally on imaging done for totally unrelated indications. Let's see an example. A 60 years old, relatively fit gentleman undergoes a master health checkup. Ultrasound abdomen done as a part of the master health checkup showed a small renal mass, 3 to 3 centimeters. Plain scan, arterially enhancing mass, delayed washout. Typical imaging features suspicious for a renal cell cancer. In this fit patient, for the small renal mass, partial nephrectomy remains the preferred option, and the aim of this video is to discuss these three non surgical options. In a patient in whom the RCC is not likely to impact the remaining life, for example, in the very elderly and with patients with multiple comorbidities, we will not do anything for the RCC, but that pathway is called as watchful waiting. Whereas active surveillance is very much different from watchful waiting, and the best way to describe active surveillance is by this picture. This is us, and this is the small renal mass. We have not decided that we'll let go of this mass, that we won't do anything. We have not taken our eyes off the mass, but we are not shooting also. We are ready, we are watching the mass very closely. If the small renal mass behaves well, if it walks away peacefully, we won't shoot it. If it makes a small move towards the gun, we pull our gun and pull the trigger. So, this is the way to describe active surveillance. This is because if 100 small renal masses are resected, 20 to 40% are benign on the final pathology. Even amongst the malignant known RCCs, which are less than 4 centimeters, 70 to 80% are low grade. So, when we tell a patient that he or she could be harboring a renal cell cancer, that is a cancer inside the body, but we are not going to do anything, these questions are common sense naturally going to follow. Of 136 small renal masses which were biopsy proven to be RCCs kept on active surveillance, there was a 44% rate of progression eventually, and there was a 4.4% chance of distant metastasis. And in another systematic review of almost 1,000 patients, the metastasis rate was 1.8%. This is the largest prospectively maintained registry on this. Patients with small renal masses, that is less than 4 centimeters, where patients chose to undergo either active surveillance or a primary intervention. The cancer specific survival at 12 years was remarkably similar. Active surveillance arm displaying a cancer specific survival of 99.8% at 12 years. The most important concept to remember is that this comparison is not between a partial nephrectomy and doing nothing. This comparison is between partial nephrectomy immediately on seeing the small renal mass and partial nephrectomy at the right time. That is, when the small renal mass showed signs of progression or bad behavior. If we fail to act at the right time, then there is no use in doing active surveillance. Before keeping the patient on active surveillance, it is mandatory to do a biopsy to avoid keeping benign masses unnecessarily on active surveillance, and also to know the histology and grade. Clear cell RCCs, we should have a higher tendency for surgery because they grow faster. The other non surgical option that we had for small renal masses was ablation, that can use either cryo or microwave or RFA. Again, like similar to active surveillance, we have to biopsy, and that is in the separate setting, not at the same time of ablation. First, similarly, if it's benign, no need to ablate, or patients may opt out of ablation. And if it's a high grade RCC, it's clear cell RCC, patients may choose a surgery over ablation. The histology in the biopsy is important because both the 5-year disease free survival and the ablation effectiveness rate are 90% for clear cell, whereas 100% for papillary. So, in a patient, how to choose between a partial nephrectomy and ablation? While counseling a patient, we should say these points. Partial nephrectomy has well established oncological outcomes without a significant nephron loss related morbidity, and any further intervention in the same kidney is possible. Either a repeat partial nephrectomy, which is less likely, or an ablation is possible. Whereas with ablation, the quality of evidence at present is low, and ablation effectiveness rate depends on the center and the location of the tumor, may need repeated ablation. And all most importantly, if we ablate a tumor and if the cancer recurs because of the intense fibrosis caused by the ablation, future partial nephrectomy becomes very difficult, almost always necessitating a radical nephrectomy, a total nephrectomy. The third non surgical option that we had was SBRT, which is not very strongly recommended at present. The level of quality of evidence is very low. So, this is reflected in the EAU guidelines. Offers surgery, strong recommendation, active surveillance,